I want to welcome everyone to today's session, Preventing Clostridioides difficile infection. This session is brought to you by Project First Line Rhode Island under the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health in partnership with the CDC. I'd like to thank everyone for joining us today and thank you all for the vital role you play in healthcare. So like I said, if you're just joining us, there's a link to the pre-session survey in our chat. Please take a minute to answer the survey if you haven't done so already. And at this time, I'd like to invite Dr. Alexis Kearney to introduce herself. She'll be reviewing the Q&A box and available post-session for a live Q&A at the end of the session. Welcome, Dr. Kearney.
Hi, everyone. I'm Alexis Kearney. I'm excited to be here with all of you today.
So my name is Stephanie Doyle. I'm an infection prevention training liaison for Project First Line Rhode Island and a community public health nurse at the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. I'll be your host and your presenter for today's webinar. I've been practicing healthcare for over 20 years, and 15 of those years as a nurse. I've worked in many different roles and have a vast array of different nursing experience, which has led me to my practice in public health and education. I'm here to present this topic to you and to help you understand the importance of infection control and prevention to help keep our patients, ourselves, and our colleagues safe. I'm so excited to be here with you today. So just a reminder, this session is 60 minutes and it is approved as a nursing continuing professional development activity by the Northeast Multi-State Division Education Unit, which is an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive your CNE credit, these 4 steps must be completed. So we talked about the pre-session survey. So if you haven't done that, please do that now. We'll be closing shortly. The second is attending this live training, and you must complete the post-session survey at the end of this training. And there'll also be a post-session quiz. So a link to that quiz will be emailed to you tomorrow. So for our other healthcare colleagues who are opting for just a certificate of training, EMS continuing education, and dental IPC continuing education, items 1 through 3 are required, while number 4 is optional. Hopefully you are familiar with our Zoom platform, but I will go over, you might see at the bottom or the top of your screen, you'll see the chat box, which I'd like to introduce Abby Anderson. She is our Project First Line Rhode Island project assistant. She will be using the chat to share links, and I will be using that also to communicate with you throughout the webinar. We have a Q&A box. I'll please ask you to post all of your questions in the Q&A box. We will address those questions either at the end of today's session, and Dr. Kearney will be joining me for a Q&A at the end, or we will email you the answers to those questions at a later time. And everyone is muted. So let's begin. If you'd like to introduce yourselves, go ahead and put your name and your organization in the chat now. And I'm glad to meet everyone. And if you're returning, welcome back. So we'll get started here. So on our agenda for today, we've done our welcome and our introductions. We will review learning objectives. We're going to talk about Clostridioides difficile, or C. diff as we will call it. We will define C. diff and review C. diff data. We will talk about the healthcare implications of C. diff. Then we will go into detail about infection control and prevention for C. diff infections. We will have some time to reflect and go over key takeaways, and we'll have announcements at the end, and we'll ask you for some feedback. All right, so let's begin. So at the end of today's session, you will be able to define Clostridioides difficile infection and other key terms, describe ways you can prevent illness by recognizing risks and identifying where germs live, identify pathways for CDI spread and how it can be prevented, and empower others to use infection prevention and control skills to promote high standards of care in healthcare settings. Yes, and we have our whole team with us today in support of this webinar as well. So the CDC has designated Clostridioides difficile as an urgent global threat, calling it an immediate public threat that requires urgent and aggressive action. C. diff is considered an epidemiologically important pathogen, which means it is an infectious agent that has one or more of the following characteristics: are readily transmissible, have a tendency towards causing outbreaks, and may be associated with a severe outcome or are difficult to treat. So in response to this urgent threat, the Antimicrobial Stewardship and Environmental Cleaning Task Force of Rhode Island has developed a C. diff playbook, which outlines an action plan to mitigate C. diff in the community. The following are the guiding principles that they've outlined to guide efforts within the healthcare system as a whole in Rhode Island to help reduce the incidence of CDI. So Abby will be posting a link to the C. diff playbook in the chat, and it will be available to you after the presentation in our resources. So the guiding principles outlined in the C. diff playbook are consistency, prevention, to minimize morbidity and mortality, and to minimize costs. And I just wanted to include a few key terms that you might hear throughout the webinar. These definitions are here for your reference later as we go through the material. You will hear them all further explained as we go. Antimicrobial stewardship, bacterial spores, colonization, List K, registered disinfectant, and healthcare associated infection, or HAI. All right, so we'll look at some data and facts. So before we narrow down and talk about C. diff specifically, I want to mention healthcare associated infections, or HAIs. C. diff is often an HAI. So HAIs are infections resulting from complications of healthcare. They are linked with high morbidity and mortality. On any given day, 1 in 31 hospital patients has an HAI. Additional infections occur in other healthcare settings. Many HAIs are caused by the most serious antibiotic-resistant bacteria and can lead to sepsis or death. HAIs can happen in any healthcare facility, including hospitals, ambulatory surgical centers, end-stage renal disease facilities, and long-term care facilities. Bacteria, fungi, viruses, or other less common pathogens can cause HAIs. The U.S. Department of Health and Human Services has identified the reduction of HAIs as an agency priority goal. HHS is committed to reducing the national rate of HAIs. So now we'll talk specifically about our HAI of concern today, C. diff, and learn a bit more about the bacteria. So what is Clostridioides difficile? So the technical definition is a spore-forming germ, bacterium, that causes severe watery diarrhea and colitis, inflammation of the colon. You may have heard it referred to in the past as Clostridium difficile, and it's often called C. difficile or C. diff. So it is a gram-positive rod, which is spore-forming. It is the most common cause of antibiotic-associated diarrhea illness, and it causes symptoms which may be life-threatening and can colonize in the gut. And as we mentioned before, a pathogen of epidemiological importance, and often an HAI, but also can be community acquired. So just a little more about spores and why it is important to know that C. diff is a spore-forming bacteria. So C. diff is a gram-positive anaerobic bacillus that can produce two toxins, toxin A and toxin B. And these toxins are secreted by the cells and are responsible for tissue destruction in CDI. So when germs are outside of the body, they become spores. Contamination and survival of C. diff spores on hospital surfaces has been reported and shown to be associated with spread through indirect transmission, which means the transfer of a germ from a reservoir where the germ lives to a person by objects or environmental surfaces. These spores are an inactive form of the germ and have a protective coating, allowing them to live for months on surfaces and in the soil. The germs become active again when these spores are swallowed and reach the gut. All right, so I'll ask for your participation here. We have our first poll question. So how long have C. diff spores been proven to live on surfaces? Is it A, 24 hours, B, 5 to 7 days, C, up to 5 months, D, 1 year? Okay, so it looks like we have 47% saying up to 5 months, and a close second, 42%, 5 to 7 days. So the correct answer is C, up to 5 months. Great job. So according to the Journal of Microbiology article titled Detecting Clostridioides difficile spores from inanimate surfaces of the hospital environment, C. diff spores can be shed to the environment by both asymptomatic and symptomatic patients and may survive for up to 5 months on inanimate surfaces. They also resist the bactericidal effect of most hospital disinfectants and most other decontamination techniques. Nice job. So as we said in review, C. diff is considered an urgent public health threat. While healthcare-associated C. diff cases have decreased some, community-associated cases have not. And why do we care about C. diff as an HAI? It's a major cause of death with increased morbidity in hospitalized patients worldwide. C. diff infections are more common and tend to be more severe in older patients who may have other serious health conditions. And healthcare settings can act as amplifiers of infection. Healthcare spread has often been an important contributor to the extension of outbreaks, which pose significant economic burden. All right, so let's review some myths versus facts of C. diff infection. So our first myth, hand washing soap kills C. diff spores, when in fact, the friction of hand washing with soap and water removes the C. diff spores. Myth, CDI occurs only in hospitals, when in fact, approximately 45% of cases are community acquired. And CDI is unavoidable in healthcare, when in fact, many cases of CDI can be prevented with evidence-based recommended infection control and prevention, or ICP, strategies. Some cases of CDI may not be preventable, but we can certainly greatly reduce. So as we mentioned, CDI is the leading cause of antibiotic-associated diarrhea and one of the most common healthcare-associated infections in the United States. So the Emerging Infections Program for Healthcare-Associated Infections has a broad surveillance area where selected territories report cases based on case definition criteria. So here we have a little bit of data that was pulled from that surveillance, and much of the recent increase in mortality of CDI is attributed to the emergence and spread of a hypervirulent resistant strain of C. diff that produces greater quantities of principal virulence toxins A and B and has additional factors enhancing its virulence. So the first step in stopping the spread of infection is identifying infection risk. When you are aware of who is at risk and how germs spread in healthcare, you can use your clinical knowledge and skill to impact decision making. Knowing how to recognize risk and take infection control actions such as implementing transmission-based precautions, is key in preventing the spread of infection. If prevention actions fail and the patient, who may be highly susceptible to infection, becomes ill, there are proven actions we can take to help keep ourselves, our patients, and our families safe. So once illness is suspected, infection control actions, such as knowing when to test and isolate, can help mitigate the spread of illness. Written protocols can be helpful by outlining a process that has been proven effective in managing patients with suspected illness. Making these protocols transparent and accessible to all members of the care team and providing ample time for education and training can establish an environment within the facility that focuses on infection control and prevention. Education that is clear and understood by everyone is vital to implementing actions that can reduce the spread of illness. Patients with a prior recent infection of CDI are likely to become ill again with the infection. Key actions to lower the incidence of CDI are follow-up and communication. Actions go beyond what is done on the front lines. A holistic approach to care involving all personnel involved in caring for the infected patient, including administrators, social workers, environmental services, pharmacy, etc., can be an effective tool for reducing outbreaks and spread of infection. These are key strategies that can be helpful in identifying and managing patients with CDI. Now we'll talk about who is at greatest risk for infection and how they may present clinically in practice. So which patients that we're taking care of are at greatest risk or increased risk for CDI? So the patients who are most vulnerable to CDI are those who have had recent antibiotic exposure, those with an immunocompromising condition, such as cancer, or use a medication that impairs their immune system, such as long-term use of steroids or chemotherapy. A history of prior CDI can increase the risk of recurrent infection. Also increasing risk is a recent or long stay in a healthcare facility, recent GI surgery, or advancing age. And even though advancing age is a risk factor, CDI affects patients across the lifespan. So clinical manifestations of the infection caused by C. diff vary from asymptomatic to severe illness, depending on a wide range of factors. The patient may present with complaints of abdominal pain, watery diarrhea with mucus or blood, anorexia, nausea, vomiting, low-grade fever. The provider may assess abdominal tenderness or abdominal distension. Diagnostic studies may show inflammation of the colon or colitis. If symptoms are severe and left untreated, the patient may develop toxic megacolon, leading to peritonitis, bowel perforation, and even death. C. diff infections range from asymptomatic infection to severe infection, which can be complicated by sepsis, perforated bowel, and may require surgery and lead to death. It's so important to recognize risk factors and test accordingly so treatment is not delayed. So a few key notes to think about when attempting to recognize C. diff versus other causes of watery stool. Identify the patient who is at risk, which we just went over in the previous slide. Submit specimens based on current recommendations, which we'll review in more detail later, and identification of symptoms. So here, now that we've reviewed who is at risk and signs and symptoms to look for in our patients, here we have some valuable tools you can use to spread awareness. So Abby will be posting the link in the chat for these printouts, which are available to you as resources for your colleagues and your patients to use in clinical settings. Here is another nice tool. You can scan the QR code and bring that right up. And Abby will also be sharing this fact sheet in the chat as well. Okay, so now we'll talk about how C. diff spreads and makes people sick. Time for our second poll question. So prevention is key in reducing and eliminating CDI. What can we do as healthcare personnel to prevent the spread of CDI? A, be aware of what antibiotics your patient is prescribed. B, know when to test for CDI. C, isolate patients as soon as possible. D, use proper PPE and perform hand hygiene using soap and water. And E, all of the above. Oh, excellent. 100% E, all of the above. All right, very good. Okay, so some of you have seen this slide before. So here's a review of the 5 elements of how germs spread and cause infection. So there are more pieces to the puzzle of germ spread than reservoirs and pathways. Germs also need to arrive at a new person. That person could be a patient or you or one of your colleagues. And in order to infect them, the germ needs to get around the person's natural defenses. If the person is already sick, then their immune system could be weak and not able to fight germs as well as a healthy person's can. Throughout all of these elements, the germ needs to survive to stay viable in the environment if they're going to make someone sick. The infection control actions that you take at any one of these points help keep germs from spreading and causing infection. So let's review this in a little more detail relative to C. diff. So germs need a pathway to be spread out of the reservoir where germs live. Think about some reservoirs where C. diff could live. As you think about where the germ lives, also think about how the germ travels or what pathways it can get into the body. So go ahead and share some of your answers in the chat. So what are some reservoirs and pathways C. diff can travel to get into the body? Countertops. Yes. How about hands? Perfect. I was just about to say that. Bed rails. Absolutely. Bathrooms, door handles. Yep. So healthcare worker hands and hospital surfaces, healthcare surfaces, environmental surfaces. So germs need to be delivered to a person and get around their body's natural defenses to infect them. Do you care for patients who are currently or have recently been taking antibiotics? They are likely ill with another infection which may lower their body's defenses and make them more vulnerable to CDI. Those who are already ill or potentially already infected, lowering their defenses. So germs also need to survive in the environment while they spread to be able to cause an infection when they reach someone. C. diff spores can live on surfaces for very long periods of time. Infection control actions at any of these points keep the germs from causing infection. So what are some actions we can take to reduce the risk of C. diff from spreading? So here we have some reservoirs here. Anyone think of any pathways? And what are some actions that we can take to help stop the spread? So Susan saying, wash hands. Absolutely. Hand washing with soap and water. Scrub hands. Great. What about those germs that are living on surfaces? Clean with bleach. Perfect. Clean countertops, patient rooms. You guys got it. Very good. Very good. Excellent. So nice job with those answers. As we know, C. diff is shed in feces. C. diff spores can be transferred to patients via the hands of healthcare personnel who have touched a contaminated surface or item. Any high-touch surface or device that becomes contaminated with feces could serve as a reservoir for C. diff spores. And C. diff spores can be transferred to patients via these contaminated surfaces by the pathway touch, either direct touch or indirectly. By the hands of healthcare workers Devices such as blood pressure cuffs and commodes, bathtubs, handrails, and bedside tables, which you all participated and shared in the chat there. Any surface, device, or material such as electronic thermometers, pulse oximeters, bedside tables that becomes contaminated with feces could serve as a reservoir for the C. diff spores. So now we reviewed reservoirs, pathways, we outlined some infection control actions. Let's go through this example scenario of how C. diff spread to a patient and made them sick. So the worker C. diff is on the healthcare worker's hands. So they did not properly perform hand hygiene and they have some C. diff spores remaining on their hands. And then the healthcare worker touches the patient's bed rail. C. diff spores are now on the bed rail. From here, how could it get to the patient? The worker's hands must have been contaminated first before touching the bed rail. The patient could pick up the germ on their hand when they touch the bed rail if it hasn't been cleaned and disinfected first. The patient could then pick up food with their hands and eat it, delivering the germ to their body. The germ has survived because the bed rail wasn't cleaned and disinfected, and the patient's natural defenses cannot fight it off. The patient now has an infection. Now, the way that I just outlined the 5 elements in this example isn't the only way germ spread could happen. In fact, there are many ways that elements could work in the scenario for an end result of a patient becoming infected. It's also important to remember that the elements that germs need in order to make someone sick aren't steps in an order, and that it is not inevitable that someone will get sick from a germ. Infection control actions can keep germs from spreading at any point: the reservoir, pathway, the new person to infect, their body's defenses, and survival of the germ itself. So now we'll go into some infection prevention and control actions. So as we know, standard precautions are used for all patient care based on risk assessment and make use of common sense practices and PPE use, personal protective equipment, that protect healthcare workers from infection and prevent spread from patient to patient. The highlighted bullet points especially apply to the care of the patient with CDI. I'll just briefly review and then we'll go into each one in a little more detail. So hand hygiene, hand washing with soap and water is recommended in the care of the patient with CDI. Use of personal protective equipment, gloves, wear gloves whenever there is a potential for contact with diarrhea. Do not wear the same pair of gloves for the care of more than one patient. Wear mouth, nose, and eye protection during procedures that are likely to generate splashes or spattering of body fluids. Clean and disinfect environmental surfaces, cell phones, defib monitors, door handles, stretchers, including straps. Utilize disposable equipment as much as possible. Disinfect tablets, laptops, phones, writing utensils. Clean and disinfect contaminated surfaces. Laundry, when you dispose of soiled linens, place in proper receptacles and carry these items away from your body, and strip beds and handle linens in a manner which avoids shaking and suspending spores in the air. And waste management. Waste that is produced from a procedure must be disposed of properly. Make sure blood, body fluid, saturated materials end up in the medical waste bags and not in the traditional trash. And standard precautions are frequently where healthcare workers can become complacent. We are busy, so the extra few minutes to perform hand hygiene thoroughly or donning the appropriate PPE can seem time-consuming. These are all small things that can make a large difference. As healthcare personnel, we have the obligation to our patients, coworkers, and our families to maintain standard precautions for infection control while caring for our patients to help keep everyone safe. So some specific guidelines for preventing the spread of CDI in healthcare. There are several measures, including performing hand hygiene, that should be applied to prevent and control C. diff infection. The following is a brief description of these key steps which should be in place when C. diff infection is present. Patients should be placed in isolation when infectious diarrhea is present and at least for the duration of their illness. Hand hygiene should be performed using soap and water. Contact precautions should be initiated once infectious diarrhea is suspected. Healthcare workers should wear gloves and gowns when providing care for patients with C. diff and should discard them immediately after they have been worn for a patient care activity. There is evidence that wearing gloves significantly reduces C. diff infection and is therefore crucial, but even with correct glove use, hand washing is the preferred method and should be performed because gloves do fail. Gloves are not a substitute for hand hygiene. Patients with C. diff infection should have their surroundings and other areas of concern, toilet areas, cleaned at least daily using clean equipment and a freshly made solution containing at least 1,000 ppm available chlorine. Air drying should be allowed following cleaning. And washing of clothing, bed linen, both in healthcare settings, using industrial processes and in the home is also important when someone has C. diff infection. Careful handling of contaminated clothing is essential in order to prevent the spread of any bacteria or its spores to hands or other items. Now we'll go into our infection control actions in a bit more detail. So healthcare workers' hands have been identified as a reservoir for C. diff. That is why hand hygiene is so important when caring for patients in healthcare. Hand hygiene should be performed before and after patient care activities. Like we identified earlier, C. diff is a spore-forming bacteria, and spores can live on healthcare workers' hands and patients' hands for long periods of time. Hand washing with soap and water is recommended when caring for patients with known C. diff, or if you are even ruling out C. diff infection. Again, the soap does not kill the spores, but the friction of performing hand hygiene using soap and water for hand washing washes away the spores, therefore reducing the risk of spreading CDI to yourself or others. Hand hygiene is a crucial action recommended for preventing and controlling the spread of pathogens within the healthcare setting to ensure that patients remain safe and that their risk of acquiring infections are minimized. Hand hygiene is an essential practice for all healthcare workers, including physicians, midwives, nurses, pharmacists, dentists, and other care providers, including community health workers and family members, in order to protect the patients and themselves. So here I have a short video from the CDC's Clean Hands Count campaign.
We all know about the growing threat of antimicrobial resistance and have seen the headlines about superbugs and nightmare bacteria. Unfortunately, this threat is very real. Now more than ever, it's critical that we work together to contain these drug-resistant pathogens and the infections they cause. Keeping our hands clean is one of the most important ways to prevent the spread of infections. Every time we enter the patient zone, we can get dangerous germs on our hands and spread them to ourselves or to other patients. Sometimes we don't clean our hands as often as we should, not because we mean to do harm, but because it's a daunting task. Some of us might have to do it 100 times a day. It takes dedication, mindfulness, and time. Our patients' lives depend on it. Let's applaud the efforts and improvements we've already made. Increases in hand hygiene adherence have led to decreases in healthcare-associated infections. At the same time, we know there is still room for improvement. We can all do better. Our clean hands count. Now, more than ever.
So as we know, use of an alcohol-based hand sanitizer is the preferred method for hand hygiene in healthcare settings. Here, we will review the best practices for use of alcohol-based hand sanitizer and when it is recommended to perform hand hygiene using soap and water. So use of an alcohol-based sanitizer is a routine method for healthcare personnel dealing with all patients, except for when your hands are visibly soiled with blood or body fluids, after using the toilet, before eating, or when exposure to certain spore-forming pathogens is strongly suspected or proven, including during an outbreak. And when to use soap and water to perform hand hygiene. Special measures for healthcare personnel in the presence of CDI use gloves for all contact with patients and their surroundings and wear a gown as part of contact precautions. When hands are visibly soiled with blood or body fluid after using the toilet, and when exposure to potential spore-forming bacteria is strongly suspected or proven, including during outbreaks of CDI. So isolate patients with possible C. diff immediately, even if you only suspect CDI. Patients with or strongly suspected of having C. difficile infection should be cared for in a single room with a toilet or dedicated commode or other dedicated care equipment until they are symptom-free. If single rooms are not available, cohorting of patients with C. diff infection should be considered in conjunction with risk assessment and infection control expertise. Because patients with C. diff infection continue to shed the organism for a number of days following cessation of diarrhea, some institutions routinely continue isolation and contact precautions for either several days beyond symptom resolution or until discharge. Depending upon the type of setting and average length of stay, it is important to know and follow your institution's policy, which may have more stringent guidelines. And Abby has a link to this graphic here that you can use in your clinical practice. So also consider use of a standardized criteria for CDI testing and be familiar with your laboratory requirements. Isolate and initiate contact precautions for suspected or confirmed CDI. Create nurse-driven protocols to facilitate rapid isolation of patients with suspected or confirmed CDI. Patients with diarrhea should be isolated while evaluation for the cause is ongoing. For suspected patients, ensure rapid evaluation by healthcare personnel and infection prevention. Place symptomatic patients on contact precautions in a single patient room with a dedicated toilet. If single patient rooms are not available, room patients with confirmed CDI together. For patients with confirmed CDI, maintain contact precautions for at least 48 hours after diarrhea has resolved. Remember, check your facility policy on that. Sometimes can be even duration of hospitalization or stay. Adhere to recommended ICP practices. Implement daily bathing or showering with soap and water. And when transferring patients, notify receiving wards or facilities about the patient's CDI status, so contact precautions are maintained at the patient's new location. So assess for appropriateness of testing. Consider other infectious or non-infectious causes of diarrhea before testing. Discontinue laxatives and wait for at least 48 hours before testing if still symptomatic. Once a patient has a positive CDI test, do not repeat testing to detect cure. Tests may remain positive for greater than or equal to 6 weeks, and tests for CDI should never be ordered on formed stool. And there you see your Bristol stool chart there. So in summary of isolation and contact precautions, use contact precautions for patients with known or suspected CDI. Place patients in private rooms, gowns and gloves to enter the room. Implement contact precautions. Use dedicated patient care equipment whenever possible. Communicate to all caregivers, family, EVS personnel, dietary volunteers what is expected, and use appropriate signage to indicate contact precautions. All right, time for our final poll question. So when can a patient with CDI be removed from contact precautions? A, never. The patient should remain on contact precautions indefinitely. B, if the patient is feeling better with only one watery stool a day. C, CDI does not require contact precautions or isolation. Or D, for the duration of illness. All right, so we have 89% that say duration of illness. So when can a patient with CDI be removed from contact precaution? The correct answer is D, duration of illness. Although facility policies may differ, according to Appendix A, type and duration of precautions recommended for selected infections and conditions, guidelines for isolation precautions in a healthcare setting for gastroenteritis from CDI, contact and standard precautions should remain for the duration of illness. Refer to your facility policy to see what is required and the criteria for removing patients from isolation. All right, so cleaning and disinfection. We want to communicate to all staff involved in cleaning and disinfection the isolation status of the patient with CDI. Read labels clearly to ensure products are effective against spores. EPA List K. Make sure all staff know who is responsible for cleaning and disinfecting in the care of the patient with CDI. If proper cleaning and disinfection products are not readily available, ask management or infection control personnel to provide, and use a formalized cleaning pattern to prevent contamination. Clean soiled areas and high-touch areas first to avoid contamination. Proceed from cleaner to dirtier areas to avoid spreading dirt and microorganisms. And this is just an example of what you will find when you visit the EPA website and you look for products that are effective against C. diff spores, and make sure you're reading your label properly. List K products are registered for use against C. diff spores. EPA has reviewed required laboratory testing data demonstrating that these products kill C. diff spores. So on there, you'll most likely see sodium hypochlorite bleach solution. You may see a hydrogen peroxide products, and a product's effectiveness can change depending on how you use it. So disinfectants may have different directions for different pathogens. Follow the label directions for C. diff carefully, including the contact time or dry time. And Abby will be sharing that link for you that will take you directly to that List K. And finally, we'll talk a little bit about antimicrobial stewardship. More than 2.8 million antimicrobial resistant infections occur in the United States each year, and more than 35,000 people die as a result. Ensuring appropriate use of antibiotics is one of CDC's core strategies to combat the threat of antimicrobial resistance. Antibiotic stewardship is also important to ensure equitable access to high-quality healthcare and to optimize treatment of infections and patients' safety. So antibiotic use is a major risk factor for CDI. Develop facility-specific treatment recommendations for common infections that include first and second-line antibiotics. Ensure that patients receive the shortest effective duration of antibiotic therapy. Include inpatient antibiotic duration when determining post-discharge antibiotic duration. As healthcare personnel, we must advocate for the best outcomes for our patients. Gaining knowledge about antimicrobial stewardship can empower us to encourage prescribers to make informed decisions about treatment options, especially those who are most at risk for CDI. And Abby also has a link for this antimicrobial stewardship CDC website that we can share as well. So our key takeaways: CDI is an urgent public health threat, but it can be prevented. HAIs can be reduced or eliminated when core practices are implemented. Identifying who is at risk is key in prevention. If infection occurs, IPC practices can prevent spread. Prevention strategies such as contact precautions and antimicrobial stewardship are key in reducing CDI. So here are some resources. You can find us on social media, Twitter, or X, I think they now call it, Facebook, Instagram, and LinkedIn. There's a link to our website, and we'll be sharing these with you at the end of the session. I want to thank everyone for joining us today for our 60-minute session. Here are our references for today's session, and those will also be forwarded to you along with these slides, the PowerPoint slides for this webinar. And again, a reminder, in order to receive your certificate of training, please fill out our post-session survey, which will be linked to you via email, and that will close in 1 week. Please make sure you fill that out in order to receive your certificate. And for those opting in for continuing nursing education credit, please fill out our post-session quiz, and the certificate will be sent out October 5th via email. And please stay for our end of session feedback poll and a Q&A with Dr. Alexis Kearney. Thank you for filling out that end of session feedback, which is different from our post-session survey and our post-session quiz. So that's just a brief 3-question feedback poll. Thank you again, everyone, for joining us. And if you have any questions, I think there was one that I saw in the chat. Dr. Kearney said she was going to go over that. We can do that. And if anyone else has any other questions, please use the Q&A box to ask your questions.
So the first question that came through was about the difference between Clostridium and Clostridioides and why that name change was made. So this happened probably about 7 years ago now. And it was originally when the bacteria was identified, it had similarities to other infectious causes that looked like Clostridium. And then as we became better at identifying and examining bacteria, we realized that there were actually some differences on a molecular level between this particular bacteria and the others that are within the genus Clostridium. So it's kind of weird, but scientists decided that it actually looked like another germ that was called Peptoclostridium. But everyone said, well, you can't name it Peptoclostridium because everything is abbreviated C. diff, CDI, and that would just be far too hard to change all of the labeling and nomenclature both within and without, both within and outside of the medical community. So they actually created a whole new genus specifically for this bacterium, and that's how we got Clostridioides. So there's really no change. The bacteria is still the same, but it's just a difference in naming that went into effect about 7 years ago.
Thank you, Dr. Kearney. I also see another question there in the chat. I don't know if you're able to answer or we can address it later. Are there specific antibiotics that tend to cause C. diff? Example, clindamycin or any others?
So I feel like the old teaching was that C. diff was most frequently caused by antibiotics such as clindamycin. At the end of the day, though, any antibiotic can cause C. diff infections. More frequent antibiotic usage, continuous IV antibiotics can all cause it. So at the end of the day, anything is fair game. And that's really why we want to focus on, appropriate and prudent antibiotic prescriptions, and really focus on antibiotic stewardship to ensure that we're using the most narrow type of antibiotic possible for a particular infection, and we're not just throwing really broad spectrum antibiotics at bacteria that could be treated with a much more narrow antibiotic. and that we're using it for only the indicated number of days, because as you're looking at more usage of more antibiotics, you're going to increase your risk of C. diff infection. So really being careful about what antibiotic we're picking, how long we're writing those prescriptions for, and ensuring that we're not using antibiotics for things that are not caused by bacteria.
Thank you so much, Dr. Kearney. If anyone has any other questions, if not, give us your email, put it there in the chat. If you think of anything after today's session, we can certainly get in touch with you via email. And if no one has anything else, I want to thank everyone again for joining us. And please make sure you check our website. We have some links to some great upcoming trainings. And I hope you guys have a good rest of your Monday.
Bye, everyone.
Try. Thanks again, everyone. Thank you, Dr. Kearney.